what makes compensated liver cirrhosis become decompensated liver cirrhosis? And by far the most common answer for this is the patient just not taking care of themselves. So what I mean is if a patient has liver cirrhosis secondary to alcohol, but continues drinking alcohol once they do have compensated cirrhosis, they're eventually going to become decompensated. Yep. So further damage to the liver. So just continuing to drink alcohol or ingesting drugs that are toxic to the liver. If you have a concurrent infection, so if you already have hepatitis, but then you do develop cirrhosis on top of that, you're more likely to become decompensated. If you're bleeding or if you end up going to shock. So I think it's very important to know this table. What's important particularly is the mortality from within 1 year. So stage 1, only 1% of people die, compared to like stage 4, where 57% of people die. So it's important to realize that there's a very sharp increase in mortality as you progress. In terms of pathology, macroscopically, the liver is initially bigger, like I said, but over time, the liver starts to shrink. And this is what it looks like. So this is more of a PAT thing than like a paper 2 thing, but I do think it's important to know. Complications of cirrhosis, the mnemonic I used was varices. So I've got that in the end, I think. Yep, so we'll go through that in just a little bit. But the main thing you want to consider is just hematological changes. So this is something that occurs in a particular order. So firstly, you get a decrease in platelets, you get an increase in INR, you get a decrease in albumin, and finally an increase in bilirubin. How important is it to know the order of this? Not that important, to be honest. How important is it to know that each of these do occur? That's pretty important. So do know that there's changes in platelets, there's going to be a change in the albumin, and there's going to be an increase in the bilirubin as well. Variceal bleeding is a very common side effect of cirrhosis as well. And I think this is an emergency station that could very easily come up in an OSCE. So variceal bleeding occurs when your hepatic pressure gradient goes above a certain threshold. And what that means is like you pretty much start vomiting blood, like you start like defecating blood, like pretty much you lose blood from your body. In terms of how it's treated, the mainstay of treatment is something called octreotide. So octreotide is a vasoactive drug. And what that aims to do is it pretty much changes the pressure of your hepatic venous gradient for like probably an hour or 2 at most. So it just buys you a little bit of time before like you really have to go and address the underlying cause. Other treatments you can do is endoscopic sclerotherapy. So you literally put an endoscope in and you start to burn off the blood vessels. You cauterize them to reduce the bleeding. And if that doesn't work either, the final treatment you can do is TIPS, so transhepatic intrajugular portosystemic shunt, which is you enter through the jugular vein and you pretty much make a shunt there. So you bypass the blood vessels that are causing the bleeding. This is a very sort of, it's something that's shown to be quite efficacious in stopping the bleeding itself, but a very bad side effect is you can become encephalopathic as a result of this. Therefore, it's something that I think you should mention as a risk factor, especially if you do get tested on it in your OSCE. Hepatorenal syndrome, an exotic thing that isn't really tested on but can come up because it's fair game. Pretty much your liver becoming decompensated can cause your kidneys to shut down as well. So there's 2 types. Type 1 is your kidneys shut down like immediately within 2 weeks. Type 2 is your kidneys gradually worsen. So you've got 6 months there. Initially, the same treatment as variceal bleeding, you give them octreotide and albumin, but eventually you need to replace the liver and the kidneys. Hepatopulmonary syndrome is again a very similar thing to hepatorenal syndrome. Your liver being affected eventually causes your lungs to be affected as well. Again, mainstay of treatment, you have to replace the liver. So in terms of general complications of cirrhosis, a mnemonic I used was varices. So the V stands for varices, easy enough to remember. You get anemia as a result of your bleeding, renal failure, that's your hepatorenal syndrome, infection. So since your body is sort of fighting the cirrhosis, it just becomes more prone to developing infections. Coagulopathy, your liver is not functioning well enough to produce clotting factors. Encephalopathy, again, hepatic encephalopathy. And lastly, sepsis. So your body's just at risk of like infection that can result in sepsis. Okay, so how do you treat cirrhosis? You treat the underlying cause. If cirrhosis is developing as a result of alcoholism, try to counsel the patient on alcohol use. If the cirrhosis develops as a result of paracetamol overdose, try and like treat the paracetamol overdose. You literally try and treat the underlying cause. An important thing to remember is you never give the patient normal saline or normal sodium lactate. So the sort of reasoning that most doctors have is the kidneys aren't really getting blood supply now because the patient's vomiting all of the blood. Therefore, I think it's important we give them some fluids. Although that is a very fair reason to give them fluids, you got to remember that the patient is at risk of developing ascites. And if you give them this fluid, it might help their kidneys temporarily, but then they're just going to get massively acidic. So it's important to like sort of keep that in the back of your head. How do you treat ascites? Low protein diet, so low salt, low protein. and you give them albumin as well, because albumin causes changes in pressure that helps the body get rid of the acidic fluid. Prognosis, Child-Pugh score is the big one. So that's this one here. So there's Child-Pugh A, Child-Pugh B, Child-Pugh C, and they're scored based on points from this table here. So how important is it to know the scoring system? Not that important. How important is it to know the things that contribute to the scoring system? Very, very important. So do know that there are 5 things that contribute to the Child-Pugh scoring system, and know that these are the 5 things. There's another thing that they can use as well called the MELD score, which is a very sort of UK British thing called the Model for End-Stage Liver Disease. And that's primarily used for determining how appropriate someone is for a liver transplant. It's not really something that's useful to us at a med school level, but I think it's good to sort of throw in as part of your spiel for cirrhosis. Okay, hepatic encephalopathy. Why does it occur? Pretty much your liver fails, and as a result of your liver failing, your body starts to accumulate waste in your body. Most commonly, this waste is ammonia, but it can be literally any waste product in your body. So things like urea, creatinine, anything. Eventually, ammonia causes changes in your pressure, which causes stuff to accumulate in your brain, and that's what causes the encephalopathy. There's 3 types of hepatic encephalopathy that I think we need to know at our level. There's type A, type B, type C, and thankfully they have easy ways of remembering them. So you have acute encephalopathy, you have bypass encephalopathy, which is often associated with TIPS, and lastly you have cirrhotic encephalopathy. It's not that important to know the types, but I feel it is quite important to know the stages of how encephalopathy progresses. So the important thing is in stage 2, you get personality changes. We were tested on that a few years back. And in stage 4, you're pretty much unresponsive. You just go into a coma. Treatment, again, aim to treat the underlying cause. So if they get encephalopathic as a result of alcohol, try and stop them drinking the alcohol, so on and so forth. Another drug that you want to give them is lactulose. Now, lactulose is something that we commonly see as like an agent that helps us with constipation. But in helping us with constipation, it also helps us literally poo out the excess ammonia in our body. So that's something we give for people who have encephalopathy. Okay, any questions on any of that? Awesome. So ascites, what is ascites? It's literally the buildup of fluid. So a question that we had in our path exam a couple of years back was, is the result of ascites, is the cause of ascites decreased oncotic pressure or increased hydrostatic pressure? Now, this was a very shitty question in my opinion, because both of them are right answers, but if you go and like really examine the pathophys, increased hydrostatic pressure has a slight higher risk of causing ascites compared to decreased oncotic pressure. This was an absolute shocking question that I'm not sure got removed or not finally, but the correct answer to that was increased hydrostatic pressure. So please know that. In terms of causes of ascites, the way we determine what the cause is by something called the serum ascites albumin gradient, and that's calculated by the serum concentration of albumin minus the acidic concentration of albumin. So these are the causes of the SAAG being greater than 11, which is most likely a result of portal hypertension. And if it's less than 11, it's a cause of something that's not going to cause portal hypertension. So pathophysiology, this is a very handy diagram that I recommend you guys have a look at when you're studying. Again, I've said here that both decreased and oncotic and increased hydrostatic result in ascites, but Monash prefers this to be a better answer for that. So yeah. Complications, the most common complication is spontaneous bacterial peritonitis. So when you do suspect someone with ascites, what you have to do is you need to suck out a little bit of the acidic fluid. You've got to check the concentration of bacteria in their acidic fluid. Does anyone know the magic number for that? So greater than 200 is, greater than 250, sorry. So if they have greater than 250 white cells per millimeter cube of their acidic fluid, they're said to have SBP by definition. This is something that was tested on in one of our practice OSCEs at Danville. So again, since it's a bacterial infection, you give them cefotaxime, so you give them an antibiotic. Treatment of ascites, you initially try to change their diet. You give them diuretics to help them pee out the excess fluid. And lastly, you give them something called paracentesis, which is pretty much you stick a needle in and you suck the acidic fluid out. What's important to remember here is if you just suck out the fluid, the body's pressure levels are going to start to get markedly deranged. Therefore, for every 2 liters of fluid you suck out, you give them a little bit of albumin back. So albumin just helps to sort of regulate the pressure. And lastly, if ascites is sort of recurrent and constantly keeps coming back, you might need to consider a liver transplant. Okay. Portal hypertension. I'll quickly go through this because I think it's all in the slides. Pretty much you get an increase in your portal pressure. In terms of causes, it's divided into causes before the liver, at the liver and after the liver. So pre-sinusoidal, sinusoidal, and post-sinusoidal. By far, the most common cause is sinusoidal, that is cirrhosis affecting the liver, but there are other causes to keep in mind as well. Complications, you can eventually get ascites and hepatic encephalopathy, which are probably the main complications because they can kill you. Clinical presentations, varices. And treatment, you give them propranolol, so you give them something to reduce the pressure. But again, if they're sort of decompensated and they're getting really bad, you consider a liver transplant. Okay, moving on to the genetic and the inflammatory liver disease. So hemochromatosis. So what is hemochromatosis? It's literally the accumulation of iron in our body. So normally our body has about 1 gram of iron accumulated. In hemochromatosis, you have up to 40 grams. So it's a pretty marked accumulation of iron. In terms of causes, it's a genetic cause. You can get like a genetic mutation in your C2A2Y allele. How important is it to know this actual gene makeup? Not that important. Just know that it's a genetic cause. The mnemonic I used for remembering the clinical presentation was ABCDH. So you get arthalgia, you get joint pain specifically in your second and your third MCP joints. You get the bronzing of your skin, so you get that tanned appearance. It can affect your liver, but it can also affect your heart as well. You get diabetes because your pancreas gets affected as a result of the increased iron. And lastly, it can affect your pituitary gland as well. Therefore, by affecting your pituitary gland, you get decreased levels of gonadotropin hormones secreted, and therefore you can get decreased libido. In terms of investigations, pretty simple. You want to do bloods to check the amount of iron in their body, and you can also consider to do a genetic analysis if need be. Imaging, you do a quick scan of their liver. You do that to determine if they're cirrhotic or not, and if you do think they're cirrhotic, you want to do continued screening of their liver just to check that they're not going to get cancer. Treatment, so a bit of a weird and a wacky one. Apparently, there's something called a hemochromatosis diet, which is avoiding red meat, avoiding vitamin C, and avoiding alcohol. The avoiding alcohol bit makes sense to me. The other two don't really make any sense, but sure, I think it's just something that doctors like to prescribe. And the big thing is venesection. So since your body has increased iron in your body, the only way you can get rid of that increased iron is if you do regular bloodletting, so phlebotomies. So what they do is, back in the day, they used to literally get the patient to come into a bloodletting lab every 2 weeks, stick a needle, let them drain out a little bit of blood, and then send them back home. That's a pretty old treatment, and I don't think a lot of patients would appreciate you jabbing them with a needle every 2 weeks. So the treatment we use now is something called desferrioxamine, which is an iron chelator. It pretty much is a tablet that binds to the iron in your blood and reduces the amount of iron in your body. Wilson's disease, very commonly seen in EMQ questions along with hemochromatosis. So again, it's a genetic disease characterized by the accumulation of copper instead of iron in your body. And it's suspected in people who are pretty young who start developing symptoms of liver failure. So again, the mnemonic I used for this was ABCD. So in Wilson's disease, you get asterixis, so you get the little fluffiness of the hands. You get basal ganglia degeneration. So the basal ganglia, if you guys remember your second year neuroanatomy, is the one implicated in Parkinson's. Therefore, if someone who's pretty young starts developing symptoms of Parkinson's, you want to consider Wilson's disease. Cellular plasmin being decreased is a very important one that I was taught by my consultant last year. So your copper goes up, but your cellular plasmin, which is the hormone in your body that binds to copper, comes down. And you get Kaiser-Fleischer rings as well, which we all remember. And lastly, you get dementia. So as a result of your basal ganglia being affected, eventually you start getting symptoms of dementia as well. So the way they sort of structure the question is the patient gets progressive dementia, which is they sort of start off okay, but then gradually over a period of a few months, they just get worse and worse. Investigations, the main one is you do serum cellular plasmin, which is going to be decreased, and you want to check the amount of copper that they're peeing out as well. Treatment, you just give them a bunch of drugs to affect the copper. So there are 4 drugs you give them. The big ones I've highlighted here is zinc and penicillamine. The other 2, I don't think we need to know at our level. Okay. Alpha1 antitrypsin. What is it? You don't have enough alpha-1 antitrypsin in your body. Pretty straightforward. In terms of clinical presentation, this is a systemic disease. So I've got this in our liver slides here, but it can literally affect any part of your body. And I think the important ones you've got to remember are your lungs. So you get your classic emphysema there. You get your kidneys being affected as well. So you get ANCA-positive vasculitis, and you get IgA nephropathy. And lastly, you get your liver being affected. I think a question we had a few years back was, what kidney, like what kidney manifestation would you see in someone with alpha-1 antitrypsin deficiency? And the answer to that was membranoproliferative GN. So I think for pretty much anything liver-based, membranoproliferative GN is like something we see that's quite common. So do remember that. Wegener's is something we commonly see as well, but I've got this as according to some studies. So if you do have both of those options in your EMQ, I would probably pick membranoproliferative over Wegener's. Investigations, you do a blood test to check for the amount of alpha-1 antitrypsin. It's going to be reduced. And you can also do a periodic acid shift stain that's positive upon liver biopsy. This is straight out of your PAT slides. Yeah, I think that's good to know. Since it's a genetic condition, it would be recommended that you start doing a little bit of genetic testing just to check for your kid's risk of developing the condition in the future. Management, not really much you can do, unfortunately. You just aim at supportive treatment. So if they get emphysema, you start treating the emphysema by giving them like Ventolin and things like that. If they get kidney problems, you start giving them steroids, so on and so forth. Okay, Gilberts and Crigler-Najjar. So this is something that I think comes up in a lot of EMQs, and probably most of you have just memorized the options by now. So 18-year-old with 1.5, the upper limit of bilirubin in their blood. But I think it's good to know a little bit about it. So what is it? So you have a very complicated enzyme called glucuronidase transferase that's involved in the metabolism of bilirubin. So in Gilberts, you have a decrease in the activity of this enzyme. In Crigler-Najjar, you have a complete deficiency of this enzyme itself. So what I'm trying to get at here is Crigler-Najjar is pretty much a severe Gilberts. That's literally the difference. In terms of etiology, it's a genetic condition. That's all you need to know about it. Clinical features, the big one is jaundice. So since your bilirubin isn't being metabolized, you start getting symptoms of jaundice. Unlike liver failure, where your jaundice sort of stays constantly, you only get jaundice at certain aspects of your life when you do have Gilberts syndrome. And the most common one is like a stressful scenario. So like before an exam, or like just if you're stressed in any way, or the other one is if you have a concurrent illness. So if you have like some sort of flu, your body's fighting the flu, and as a result, your liver is sort of like already in like overdrive, and therefore you start getting symptoms of jaundice. Investigations, I've literally got the buzzword from the exam here, 1.5 times the upper limit with no other features. And treatment, you don't need anything. It's a benign condition. Once your stress goes away, your jaundice will go away as well. Okay, acute liver failure. There are three things that make acute liver failure acute liver failure. The three things are jaundice, coagulopathy, and hepatic encephalopathy. Please know these. These are very important things to know. Like, it can come up in an OSCE, can come up in an exam, can come up in your wards as well. There must be no evidence of previous liver disease as well. So what I mean by that is if someone has like a past history of 50 years of hepatitis C, and then they get these symptoms, you can't really say he has acute liver failure. It's probably acute on chronic liver failure. Acute liver failure is there's no past history of liver disease, and then they get these symptoms. In terms of classification, I've classified these into two different types. You have by time and by fulminancy. So by time, it can be hyperacute, which is under a week, acute or subacute. Fulminant or subfulminant just determines on how severe the actual symptoms are. So fulminant is if all three of these occur within a period of 2 weeks. Subfulminant is it occurs up to 12 weeks. So it's not that severe, but it's still pretty important to manage. In terms of etiology, most common cause by far is the viral one in the developing world. In sort of the developed world, like Australia and other Western countries, it's paracetamol overdose. So just someone who takes a lot of paracetamol can get acute liver failure. And that's just a drug highlighting that. Pathophys depends on the cause. So if you have paracetamol, for instance, the way that it damages your liver is very different to, say, like gallstones affecting your liver, for instance. Clinical presentation, you get jaundice, you get encephalopathy, you get fetal hepaticus, which is your breath smelling like pear drops. You get asterixis, and you get constructional apraxia. So this is a very fancy word for the one where you're like, can you draw a 5-pointed star for me? And the patient draws something like that. So that's constructional apraxia. Another sort of slight point that I think would be good to know is the differentiation between asterixis and CO2 retention and asterixis and hepatic encephalopathy. In CO2 retention, you're breathing, but you're not breathing appropriately. Therefore, your body's sort of retaining CO2. Therefore, your asterix is gonna be like a nice sort of flappy, regular one. In encephalopathy, you're sort of having derangement of the enzymes in your body. Therefore, your asterix is gonna be like more sort of irregular, and like there's not a pattern associated with it. So again, a very small thing to note, but I do think it's nice to know in the back of your head. Investigations do everything to check the liver. So LFTs, PT-INR, basic metabolic panel. The big one here I've got is arterial blood lactate levels. So one of the questions you've had in your past year 3 exams is someone comes in with like having 48 Panadols. What is their blood gas going to show? Is it acidotic, alkalotic? Is it metabolic, respiratory? And I think it's good to do an ABG to sort of determine what their blood gas levels are. Treatment, treat the cause. If it's a paracetamol overdose, treat that. If it's like a viral cause, treat the virus, so on and so forth. In terms of ED management, the big one I've got here is you want to do a head-up tilt in the trauma unit. And the reason for that is you aim to decrease the blood volume in the center of the body. You want to increase blood flow to the back of the brain because that's a pretty important organ. So the other things you can do is you can give them glucose because they might be hypoglycemic, and you give them lactulose to treat the encephalopathy as well. So just taking a quick detour and talking about paracetamol overdose now, I think this is something that I unfortunately wasn't taught very well at all. So it's something that I had to learn myself. Paracetamol overdose can be divided into 3 categories. So someone has paracetamol and comes to the hospital within 1 hour, they come under 8 hours, and they come after 8 hours. So if it's under 1 hour, the body hasn't really absorbed most of the paracetamol yet. Therefore, you give them activated charcoal. So charcoal has a really high surface area, and it can literally suck up the paracetamol from their stomach. So the body isn't really absorbing anything. If they arrive at hospital after 8 hours, you want to give them something called NAC, or N-acetylcysteine. Now, N-acetylcysteine is pretty much an antidote to paracetamol. And at this point, you can't really give them activated charcoal because the body's already absorbed the paracetamol. Therefore, you want to give them something to sort of address the absorption rather than address the paracetamol itself. I think that's the salient point I wanted to make in this slide. And then after that, you just continue monitoring them and see how they progress. Okay. Sorry, question. Sorry? If they're in between 1 to 8, you do give them activated charcoal still, but on the back of your mind, you would be considering a NAC infusion. So I think the important thing that I wanted to differentiate between is like under 1 hour and over 8 hours. 1 to 8, you sort of do both, and you just sort of continue monitoring them. I think eventually, if you sort of follow the flowchart here, they do come to a NAC infusion eventually, because NAC is by far the gold standard, but NAC is something we don't give everybody. We want to see how they respond to charcoal before we do give them NAC. Yep. Awesome. Okay. So I said I'll have a quick chat of LFTs as well, because I do think it's quite important to know. So most of you hopefully are quite familiar with the concept of LFTs and can like use the mnemonics we learned in second year. Like if I say all liver things and some things, all liver plumbing, gonna get trashed. Does that ring a bell at all? Or okay, that sounds very complicated. Okay, so let me quickly go through that. So there's 4 aspects of LFTs that we look for in addition to the albumin and everything else. So you've got 2 things that give you a more of a hepatic picture, so things that affect the liver, and you've got 2 things that give you more of a cholestatic picture, so things that affect the biliary tree. So the way I remembered this was all liver things. So this is everything to do with the liver itself and something. So this is again more of a liver picture, but you can see raises or drops in this in other causes as well, particularly with drugs. The way I remembered these 2 was all liver plumbing. So this is to do with the biliary tree itself. So things like gallstones and everything might cause a rise in this and gonna get trashed. So alcoholism is gonna cause a marked increase in GGT and maybe a slight increase in ALP. So I've got like notes and all of that here. So full LFT is made up of a few things. You've got your ALT and AST. You've got your ALP. You've got your GGT. So just quickly talking about that. ALP is really important in Paget's disease of bone. If you do have that condition, you'll get an isolated increase in ALP, but everything else is quite normal. GGT, as we said, is going to get trashed. That's the alcoholic one. So if you do have an alcoholic picture, you're going to see that in like the thousands, but everything else is going to be fairly okay. ALT and AST both are specific for the liver, but like we said, AST is not as specific for liver damage as ALT is. So in things like rhabdomyolysis, heart attacks, and hemolysis, you might see an increase in AST, but ALT won't really be affected. Other things that are important is albumin. So albumin is a very easy thing to remember. If you do have liver damage, it goes down. Normally it should be up. It just goes down if you have liver damage. And bilirubin as well. So what I found slightly confusing is the ratios of AST to ALT. So if you do have an increase in both AST and ALT, you do know that it's going to be something affecting the liver. The question is, what could it be? So if the ratio of AST to ALT is less than 1, so say that AST is like 500, but ALT is 1,000, it's most likely going to be something directly damaging the liver. So hepatocellular damage is the primary diagnosis. If AST and ALT are virtually the same numbers, so things like 700 to 700, it's ischemia of the liver. So something affecting blood flow to the liver itself. And lastly, if AST is like 2,500, but ALT is like 300, that's a result of alcoholic hepatitis. So at that point, you're going to see a rise in GGT as well, but you're going to start seeing things affecting the liver. Now, these ratios are something that you should probably take with a grain of salt because different doctors look at it differently. But I do think it's good to know for like your EMQs, because if you do get a question with multiple options that are hepatocellular damage, but you want to sort of differentiate between what the actual cause is, it would be good to look at the ratios then. Yeah. Okay. So in terms of drug-induced liver disease, the type of injury may be either hepatocellular, might be cholestatic, or might be mixed. And the way I differentiate that is on the ALT-ALP ratio. Now, again, this is something I got of Wikipedia, and I think it's a very specific table that wasn't really tested on, but it's probably good to know what drugs can affect the liver enzymes in what ways. So things like paracetamol are going to directly affect the liver. Therefore, the ALT to ALP ratio is going to be very, very high. Things like steroids also affect the liver as well, but when you think steroids, you want to think of like a pancreatic picture. Therefore, it's going to be like the ALT to ALP ratio is going to be less than 2, so it's going to be very small. And lastly, things like amitriptyline, phenytoin, carbamazepine, so all of the anti-epileptic drugs, the ALT to ALP ratio is going to be relatively constant. So we're looking at between 2 to 5 there. So what I'm trying to get at here is that things like steroids or OCPs, which can affect the pancreas, are going to cause a marked increase in your plumbing, so the biliary tree. Things like paracetamol, which are directly going to affect the liver, are going to cause a marked increase in your ALT, so directly affecting the liver. And other sort of anti-epileptic drugs, which not just affect the pancreas, but can affect the liver as well, are going to have like a fairly constant ratio. I've also got a quick table here on bilirubin and urobilinogen. I'm quickly going to skip over that, but that's there just for your learning as well. Okay. Any questions on any of that? Oh, geez. Okay. I think I'm well over time already. I'll try and aim to finish within the next 10 minutes, but yeah, sorry about that, guys. Okay. Budd-Chiari syndrome. If there's a triad, it's defined as a triad of abdopain, ascites, and hepatomegaly. Why does this condition occur? It occurs as a result of your hepatic vein being blocked. So in 75% of the cases, your hepatic vein is blocked as a result of thrombosis. And the other 25 cases, the hepatic vein is blocked as a result of a tumor. Pathophys, you get something called nutmeg liver, buzz, very common pat buzzword. And investigations, since it's something affecting the hepatic vein, you want to do something that visualizes the vascular system. So angiography is something that we would consider. Treatment, if it's the thrombosis, you want to get a shunt to sort of divert the blood flow around the thrombus. If it's a tumor, you do surgery to remove the tumor. If it's a very severe thing that can be treated by, that cannot be treated by either one of those, you do a liver transplant. Okay, cancers of the liver. We'll quickly skim through this. So most common hepatic tumor is a hemangioma. Buzzword for this is a cotton wool appearance. Please know that. That's what it looks like. Focal nodular hyperplasia, you get a central stellate scar. Again, another buzzword, so just memorize the buzzwords. Adenoma is a very common one that we're going to see, that you might see in your OSCEs. The most common thing associated with a hepatic adenoma is your oral contraceptive pill. So anytime, this is more of a fourth year thing again, but like if you do get a patient who's like on the oral contraceptive pill in your OSCE, ask them if they've had any symptoms of like vague upper quadrant pain or like loss of weight or anything like that. Okay. Malignant cancers of the liver are most commonly hepatocellular carcinomas, and they occur in older people. So in terms of like an OC health thing, vinyl chloride is associated with an angiosarcoma. So I think you guys might remember this from your OC med thing. Have you guys had the John Desmond quiz yet? Okay. Are you guys planning on doing it or? Okay. Do it. Like I think it's good preparation for the actual part 1 paper because a lot of questions can be repeated. Yeah. Okay. Clinical presentation, cancers of the liver, you get typical cancer symptoms, but you also get ascites. So that's the big thing there. Investigations, alpha fetoprotein is the big In terms of treatments, if it's a cancer, you do surgery. You can't really give them like adjuvant chemotherapy or anything like that. But the important thing to remember is if they're acutely cirrhotic, you think back to your Child-Pugh score, and then you consider whether or not you do surgery. Because if the patient has a risk of like 60% of dying on the table as you do the surgery, chances are the surgeon's not going to operate on them. So you've got to consider that as well. So in terms of metastases, remembering John's presentation just a couple of hours back, one of the questions was a woman comes in with symptoms of like blood in her stools, and her mum died from a cancer that went to the liver. So colorectal metastases are the most common. So like colorectal cancer metastasizing to the liver. So keep that in the back of your mind. Okay. Hepatic abscess, pretty simple condition. You just get an abscess. So the abscess is like a collection of pus. Common causes include bacteria, parasites, fungus, and you just get classic infection symptoms. So the buzzword for Monash is swinging fevers with an abscess. Sorry. So you get like a fever of 40, then you get a fever of like 37, then the next day you get a fever of like 41. So you very sort of labile. Investigations, you do an FBE, and the reason you do an FBE is you want to check if their white cells are up. And the imaging of choice is an ultrasound. You don't really do a CT, you just do an ultrasound. That should be sufficient. Treatment, suck the abscess out. Like there's literally nothing else you do. And if the abscess is a result of an bacteria, you give them antibiotics after. Gallstones in the biliary tree. Okay, final question for a Kit Kat. Just raise your hand, guys, if possible. Okay, okay, yep. Perfect. Oh! I was so sorry. So sorry. All right. Okay. All right. No lasting injuries were done in the throwing of that Kit Kat. Okay. I am so sorry. I'm so glad that this is not being recorded now. Like, oh. Okay. Okay. So that is PBC. We'll quickly go through the conditions there. So in terms of the different conditions affecting the gallbladder, you've got inflammation of the gallbladder, you've got stones, you've got inflammation as a result of the stones, and lastly, you've got colics. So there are 4 conditions there. I think it's important to know the definitions of each of these as well. So I've got them there. Just have a look at that in your own time. And in terms of epidemiology, it's a very common condition. Okay. Gallstone ileus is a side effect that you get as a result of gallstones in your body. And what it is the gallstone literally forms a fistula that enters your small intestine, and that causes blockage of that causes small bowel obstruction. So the obstruction causes 3 features on imaging called Wriggler's triad. So what that is you get air within the biliary tree, so pneumobilia. You actually get obstruction of the small bowel itself. And if you do look closely enough, you can see the gallstone within the imaging. Treatment, you do fluid resuscitation, but eventually you do surgery. So the aim is to just suck out the stone, and therefore once you do that, the patient should recover. Etiology of cholecystitis. So cholecystitis is inflammation of the gallbladder, and most commonly that occurs as a result of gallstones. You can get bacterial causes as well. So the mnemonic I used for that was beekeeps. So Bacteroides, Fragilis, Klebsiella, E. coli, Enterococci, Pseudomonas, and Serratia. So the big ones I think you got to know here are Pseudomonas and E. coli. Secondary infection with gram-negative bacteria can occur as well in cholecystitis without gallstones, and TPN is another big thing that you got to consider as well. So in terms of risk factors, the mnemonic that we were taught was the 5 Fs. So fair, so it's more common in Caucasians. If they're fat, so a BMI of greater than 30. If they're female, if they've had greater than 1 child, and if they're above the age of 40. So again, a very nice thing to pepper through in your OSCEs as you ask the patient questions for like risk factors. Pathophysiology, I've got like a whole heap of things there, but pretty much a TLDR, you've got a gallstone, it blocks things. The blockage of things causes bacteria to accumulate there. Bacteria eventually just eat away at the tree and you get necrosis. In terms of stones, this is more of a pathology thing than an EMQ thing, but you need to know the different types of stones themselves. So there's cholesterol stones, which are the most common, which look like yellowy, like cholesterol colored. You've got bilirubin stones, which because of the bilirubin make them look black. And lastly, you've got mixed, which is a combination of cholesterol and bilirubin. So the important thing is mixed stones can be seen on radiographs. The other 2 might not necessarily be seen. In terms of complications, you get gallbladder mucoceles, which is as a result of obstruction, you start getting the development of mucus accumulation there. And eventually you can get Gilberts Syndrome as well. So Gilberts Syndrome is a very rare condition in which extralimital compression can result in cancer. So a pretty rare thing. Complications, cholangitis, pancreatitis, and biliary cirrhosis. And the big presentation that hopefully you guys remember from now is Murphy's sign. So you press down on the gallbladder, you make the patient take a breath in. As they're breathing in, they catch their breath. That means they have a stone there. Sorry, that doesn't mean they have a stone there. It means they have inflammation of the gallbladder, which could be a result of a stone. Another thing that Monash liked to test us on was radiation of the pain to the right scapula. So that's called Boas sign. Again, something that's quite uncommon, but could be a possible question. Choledocholithiasis, since it's blockage of the biliary tree, you start getting jaundice symptoms as well. So things like pale stones and dark urine. Investigations, ultrasound is the one of choice since the stones can be seen on ultrasound. And you can do LFTs as well to check for like an ALP and a GGT rise. This is a handy table that I ripped off Oxford handbooks. So in differentiating between colic, cholecystitis, and cholangitis, cholangitis has your triad, so Charcot's triad. The other two have, so cholecystitis doesn't often come with jaundice. Biliary colic just comes with right upper quadrant pain. Okay. Treatment depends on the cause. So if it's gallstones, you do a cholecystectomy. If it's like biliary colic, you just give them pain relief and hope for the best. Cholangitis, I'll quickly skim through this. Yeah, you get Charcot's triad. So Charcot's triad is jaundice, upper quadrant pain, and fever. If you get decompensated cholangitis, you get Raynaud's pentad, which is the same thing as Charcot's triad, but you also get hypertension and your mental status is affected. Okay. In terms of investigations, ERCP is the one of choice. Why we do ERCP as first line is it's not just diagnostic, it's therapeutic as well. So once you do the procedure, you can sort of treat it then as well. Management, if you do the ERCP, you can treat them there, but every patient, you just remove the gallbladder. PBC and PSC, quick skimming through of this. So PBC is chronic disease of the small ducts. PSC is chronic disease of the medium and the large ducts. That's what differentiates it. In terms of epidemiology, PBC is commonly associated with Gilberts Syndrome, whereas PSC is associated with inflammatory bowel disease. So most commonly UC, but can be seen in Crohn's as well. Etiology, autoimmune. Both of them are autoimmune. Management with PSC, you want to with PBC, you want to consider liver transplants. With PSC, you consider liver transplants, but you aim to sort of treat the underlying bowel condition as well. So this is the slide that went through the question we did earlier. Yeah. Oh, do we actually? Okay. Okay. All right. Clinical presentation. Go through this for OSCEs. Ask these questions for OSCEs. Handy pictures, handy pictures, handy pictures, handy pictures. Jaundice, prehepatic, hepatic, posthepatic. Please know that. And done. Sorry, guys. I think we were running late. Like, previous one finished in like 15. So.
Oh, okay.
Yeah. How you doing?
Not done? Yeah.
Sorry about that, man.
No, it's fine, it's fine. Yeah, I think I was going over time anyways, but yeah.
Yeah, thanks so much. If you just want to send the post slides to Manoj,
yes.
He'll upload them. But, yeah, thanks so much. Hey man, how you going? Yeah, so you're doing the renal presentation? So I just need to jump it on USB. So I'll just add that here. So the deal is that we've got it both on. So because we can't directly stream from this thing here, we have to stream from this computer and present from this computer. So I think all you have to do is essentially make sure that the slide on your computer here is the same as the one that's showing up here.
Okay.
Let's go.
That's what we see.
So that's one to see on. Okay.
Yeah. And this is the one.
And then where do I click?
You click like either here and like just like space bar or something.
Also, it's two at a time. Okay. Dude, my stuff. Stay calm, stay calm. I feel my heart palpitating.